Solutions for the health problems we have currently in our country are actually can be solved by changes in the health systems. So you realize that most challenges we have are related to quality of services we provide, and of course, this quality of services we provide are influenced by the human resource, the finance, and the processes that are involved in provision of this care. So you'll find as part of the system are the health providers. There are also factors that are relating to patients. So then human capital is basically the capabilities health providers are as the human capital that provides these intangible assets that are health services. So these intangible services, of course, include services like preconception care. And preconception care basically is the provision of biomedical, behavioral, social interventions that are targeting mothers before they actually conceive. So this is the zero trimester, they say, so that which is really important and a major contributor to the outcomes of pregnancy. Okay, so you'll find that globally preconception care engagements are suboptimal, and yet we've seen that, and also it has been shown that physicians, nurses have a great influence on provision of this particular care. Then, of course, their knowledge and perceptions are very important in the way they provide the care. So you'll find that in Kenya, we have challenges with preconception care. Despite the fact that the WHO had a policy statement in 2012 that showed what we should do in terms of providing preconception care. And in other places, actually, it's being provided and it's actually packaged. Okay? But then we see in our settings, it's not, the focus is very little. And you'll find that emphasis has been on the other trimesters, that is the antenatal, natal, and postnatal periods of pregnancy. And of course, only a few places or interventions have been based on preconception care. And I think it's all around the people living with HIV and AIDS. And yet everyone actually needs this particular intervention. So could be that this may have resulted in the current bad indicators we have in terms of reproductive health. So, and our policy document states that we have gaps in resources, more so in terms of the skills that we have that are supposed to be useful in provision of these services. And probably these skills also could be the reason why we don't have adequate engagements in terms of preconception care. So this particular study looked at the rates of engagement in terms of provision of preconception care and how it is affected by the human capital, who are the health providers in Kisumu County of Kenya. So basically, it was done in Kisumu County. It's a cross-sectional study that was both descriptive and analytical. So it used both qualitative and quantitative approaches, and it's supposed to just create synergy between the two methods. So the study population were health providers in the selected health facilities within that county. So, and these health providers were sampled through a multi-stage sampling, where we had stratified the county into 7 stratas, depending on account of the sub-counties, and then purposefully selected the 4 levels of facilities, that's from level 2, 3, 4, and 5. And then now we had a sample size of 479 health providers selected from these particular facilities. So data was collected using checklists, self-administered questionnaires, and focus group discussions. This data was managed, or rather it was cleaned, entered in SPSS version 25, and then various statistical analyses were done. Mainly the student t-test was used to analyze the significance of the differences in the means for the various rates of preconception care provision. and then also multilinear regression to just show the association between these various factors in terms of health providers and provision of care. So the key findings basically that, as we had seen again in other studies, that the engagements in terms of preconception care are very few. That is about 39%, which is suboptimal. Although it's similar to other studies that have been done elsewhere that are approximating it between 18 and 37. But then we realized that there is actually need for us to work and put more effort to ensure that it actually increased and it's at par with the other interventions that are provided through the continuum of maternal care. So basically this is just a graph trying to show the various services that are contained in the package for preconception care. You realize that we have the challenge in Kenya that we've not packaged this together. So you'll find that most of these services are just given alongside other packages. But then, of course, they do serve the purpose of being part of the preconception care. So basically, most of the ones which you find are scoring highly are the ones which include HIV prevention. We know that we have programs that target HIV, but then, of course, in one way or another, they do influence the preconception period. Then about human capital characteristics, we realized that there are knowledge gaps. Though we were able to appreciate that at least 55% of the health providers had an idea of what preconception is all about. But then, of course, and it is better than in other countries which have done a similar study in Africa. That's basically in Ethiopia, where we saw 31%. But then it was shown that doctors had more knowledge than nurses and other health providers. So you see that lab technicians and nurses who are doing poorly in terms of the performance, in terms of knowledge, you'll find that they are scoring around 29.9%. So it means that, and then it was showing that actually the differences in level of knowledge, you find that the ones who work in higher hospitals tended to be more knowledgeable as compared to those ones who are working in primary facilities. And it's actually a finding that is very similar to others which have been done before, like this study in Ethiopia by Kasa et al. So then again, but then the good thing is that we realize that staff do appreciate that preconception care is important. So it gives us leverage to say that actually if they're given empowered to provide this care, they are positive that they can actually do what? Provide the care, which is really important. This is a table showing the various scores in terms of their knowledge levels. So further, when you try to analyze and see the significance of these characteristics they presented with and how they provided care, it was shown that there was a significant difference in the means of provision between nurses and non-nurses. That suggested that nurses were less likely to provide care. And yes, we know that nurses make the biggest workforce. Okay? So this is in keeping with other studies, which are like the one in Egypt by Elu. And we realized that, that the mean provision for preconception care was found to be lesser in those who have more experience in the field. So the younger nurses tended to have more knowledge than the ones who have been there for a while, and we thought could be relating to the fact that maybe the curriculum has changed over time, and we hope that maybe in this case we need to have some in-service training for the ones who have been there for longer. So then, but also this was this was also alluded to the conversations we had in terms of focus group discussions that did express the concern about having information added or given opportunities for them to learn around about preconception care. So basically, if you look at this, this is the linear regression analysis. It basically shows us there are two particular findings which are very significant. We're looking at the p-values there, that experience up to 5 years and experience more than 5 years, you're seeing there's a significant difference in the means of provision, where those ones who are up to 5 years were scoring better than the ones who have had experience more than 5 years. And then we are seeing there nurses scoring less compared to the other health providers. So we were lumping the rest together because of the numbers they are. So for the sake of analysis, thank you, we did that. So basically, the conclusions, I've been mentioning them alongside discussion. So basically, we realize that the PCC provision is low at 39, and it can actually be influenced by health provider characteristics. And we recommend that we have trainings for these health providers to be able to increase this engagement. Thank you.